Welcome to this channel made for me. In this video, we will learn about acute rheumatic fever and we will touch some parts of rheumatic heart disease. We will start with the pathogenesis, then Jones criteria, clinical feature, investigation, and finally the treatment. So let's begin. So acute rheumatic fever, it is caused by the Group A beta hemolytic streptococcus infection. It is caused by Group A beta hemolytic streptococcus infection, that is also known as gas infection. What actually does is that this organism causes pharyngitis. If the patient is having allele like allele HLA, DR4 and DR7, then they are at risk of having acute rheumatic fever. But if allele is DR5, DR6, then they are protective against this acute rheumatic fever. So these are the two alleles which we should know. And now after 2 to 3 weeks, after 2 to 3 weeks of pharyngitis, what happens is that if this is the streptococcus infection, if streptococcus organism, okay, and streptococcus means like they are in groups. So if this is the streptococcus organism, then they are having proteins like M protein. They are having like proteins like M protein, and the cell wall of this streptococcus organism has carbohydrate, that is N-acetyl glycosamine. So one is M protein, another is N-acetyl glycosamine. So our body makes antibody against this M protein and NAG. Now the antibody which is formed, they cross react with our body proteins, like they cross react with the cardiac proteins like cardiac myosin, sarcolemmal membrane proteins, and they activate the complement system, like C3A and C5A releases. What it causes is that it calls the neutrophils and macrophages. Now what they do is that they start inflammation and tissue injury, due to which different manifestations of acute rheumatic fever occurs. In heart, the epicardium, myocardium and pericardium, what happens is that there is the formation of Escov bodies. What actually it is one of the type of granulomatous inflammation. I will show you the picture. Here we can see that this is the cardiac myocytes. And these structures are the macrophages, and these black dots, these are lymphocytes. This area is necrosis. Which type of necrosis? It is fibrinoid necrosis. And we can see that this size of macrophage and this size of macrophage is different. So this is activated macrophages, and normally if this is the size of macrophage, then in the second one we are able to see that the size of the macrophage increases and the cytoplasm also increases. And this, if it is taken on the longitudinal section, then what we see is that we see a caterpillar like structure. So here we are seeing that there is the longitudinal section of the macrophage, and we are seeing the activated macrophages with abundant cytoplasm and caterpillar like and if we see this image, then this is also the macrophage, and we are seeing that this is in the cross section, and we are seeing image like owl eye. It is like this. If this is the owl eye looks like this, and we are seeing this type of similar structure here. So this is owl eye like appearance. These are the two different appearance of macrophages, and here we are seeing that we can now we should know that this type of macrophages are called as the anitschocele. Anites, ANITSCHKOW, anitschocele. And here we are seeing that there are the multinucleated fused anitschocele. What are these? These are multinucleated fused anitschocele, and these are called as Escov giant cells. So this overall structure is called as Escov bodies. Okay, and it is found in heart. Now we have to know that the age group which is common in acute rheumatic fever is 5 to 15 years, and for sex, there is no clear gender association of acute rheumatic fever, but in case of rheumatic heart disease, females are two times the incidence of rheumatic heart disease is frequently found 2 times more in females than in males. So we have to know this rheumatic heart disease prevalence. And the common age group for rheumatic heart disease is 25 to 40 years. So overall, the type of hypersensitivity reaction during acute rheumatic fever is type 2 hypersensitivity reaction. Type 2 hypersensitivity reaction. This one is the important one. Now we will learn about the revised Jones criteria. Previously it was only just Jones, but now it has been revised, and it was revised in 2015. Now for that we have to know that there is two types. One is low risk and another is high risk. So who are the populations under the low risk and high risk? So if there is incidence of acute rheumatic fever, less than or equals to 2 per 1 lakh school going children, and the incidence of rheumatic heart disease less than or 1 per 1000 population, then they are termed as low risk. But if this definition do not match, then if this definition do not match, then they are termed as high risk. Okay, so acute rheumatic fever incidence less than or equals to 2 per 1 lakh school going children, or incidence of rheumatic heart disease less than or equals to 1 per 1000 population per year. It is per year. Okay, it is also per year. So they are low risk. If this definition do not match, then it is high risk. Now what has been revised is that previously we just write the carditis, arthritis, but now it has been revised. So let's see what has been revised. So first I will write the low risk and high risk. In Jones criteria, there are major criteria and minor criteria. Okay, so in major criteria, if first we'll talk about low risk and simultaneously we'll talk about high risk. So in major criteria, we have one mnemonics regarding this criteria, that is Jones. Jones. So at first we will talk about J means joint. Okay, so joint, in joint, if there is low risk, then there should be polyarthritis. But in case of high risk, if there is monoarthritis, it can be also considered as major criteria. So if there is poly or mono arthritis, then it can also be considered as major criteria. Also, if there is polyarthralgia, no need to have inflammation, just if there is pain, then also it can be considered as major criteria. Okay, so first one is joint. Now O means this type of heart. So in heart, if low risk, there should be carditis. It can be clinical or subclinical. Previously there was only clinical, but now it can be subclinical also. And similar is in case of high risk. Carditis clinical or subclinical. Okay, now the third one is N means nodules. So what type of nodules? Subcutaneous nodules. Same in the high risk. Subcutaneous nodule. At fourth is there is nodules also one. E for erythema marginatum. Similar is here, erythema marginatum. Now at fifth is S. So S means Sydenham's chorea. Similar in the high risk also. Sydenham's chorea. It is also called as St. Vitus dance. We will talk in detail after completing this major and minor. Now let's talk about the minor criteria. So in minor, so in case of minor criteria, we I basically remember mnemonic as iteria, iteria. From criteria it is iteria. So at first we'll talk in about this low risk and high risk. So in low risk, the first one is increased I means increased WBC, increased WBC, which means leukocytosis, leukocytosis. Similar in the high risk, leukocytosis. The second one is T. T means temperature. So increased temperature means fever. The fever in low risk is it must be more than 38.5 degrees centigrade. But in case of high risk, if fever is more than 38 degrees centigrade, it will be considered as minor. So now in the third, E means ESR or CRP. So raised ESR and CRP, the values are different. Like in case of ESR in low risk, it must be more than 60 mm per hour, and CRP is more than 3 mg per dl. In case of high risk, the ESR is, if ESR is just 30 mm per hour, then also it can be considered as high risk, a minor in high risk patient, and the value of CRP is same, more than 3 mg per dl. Now this R means actually the PR. So PR interval prolonged, PR interval prolonged. Normal PR interval is 0.1 to 0.2 seconds, but in case of acute rheumatic fever, this interval has increased to more than 0.2 second. So it is the first degree heart block, and the value is same as PR interval in case of the high risk. PR interval prolonged more than 0.2 second. Now the last one is A. So there is nothing about I, and the last one is A. So A means arthralgia. In case of low risk, we consider polyarthritis, but in case of high risk, monoarthritis can also be considered as in minor criteria. And for the diagnosis of acute rheumatic fever, we should have two major criteria, or if there is only one major criteria, then it should be with two minor criteria. Along with, there should be supporting evidence of streptococcal infection. What does it mean? That there should be recent scarlet fever history, which is assumed as if there is disformation of the skin of palms and soles within the previous 2 weeks, then it is considered that there is evidence of recent scarlet fever. And also, if the anti-streptolysin titer O is raised, then it is also the evidence. And if there is positive throat culture, then this is also the evidence for streptococcal infection. First begin with the carditis. So carditis means the inflammation of heart. So it in 60% of the cases, in 60% of the cases, pancarditis occur. Pancarditis occur. What does it mean? That there is involvement of both pericardium, myocardium, and endocardium. And mostly it involves the endocardium. So endocardium is mostly involved. So there is mostly endocarditis. Okay. In endocarditis, the most common valve affected is the mitral valve. So it can lead to the mitral regurgitation. In case of mitral regurgitation, there occurs the pansystolic murmur. And sometimes what happens is that there occurs the transient apical diastolic murmur. Which means the Caricombs murmur. And after this mitral valve, the second valve which is most commonly affected is the aortic valve. And we should also know that if this pericardium is involved, there occurs the pericardium. There may occur the pericardial friction lobe. Along with some evidence of pericardial effusion. So these are the things which we should know in carditis, and they basically clinically manifest with features like breathlessness, chest pain. Now we will secondly learn about the joint, that is polyarthritis. So in case of arthritis, there must be two or more joint involvement. Should be involved, and if there is involvement of only one joint, then it is not considered as a major manifestations. And the joint which are involved, they migrate from one joint to another, so there is migratory fashion. And the joint which are involved are asymmetrical. And there is the joint involved, there is inflammation, but that inflammation is non-erosive type. And the joints which are involved are mostly the larger joints. So large joints involves like knee joint, hip joint, shoulder joint. Okay, so they basically manifest with features like this joint pain, swelling, redness, and their duration is less than 4 weeks. So these are the things which we should know about the arthritis. Now at thought, let's know about this Sydenham Chorea. In Sydenham Chorea, Actually it is the last manifestation which manifest if all the other symptoms get disappeared, then this symptom appear, and it is also known as scent vitus dance. Scent vitus dance. And in this symptom, what happens is that there is the abnormal body movement, and there is development of ataxia. There is development of development of ataxia, slurring of speech, slurring of speech. There is emotional emotional instability, and there occurs the involuntary movements. And when the patient sleep, these symptoms disappear. So during sleep symptom is disappeared. Okay. And this is actually the self-limiting. And it may last up to 3 months. Fine. Now we will talk about the fourth feature, which is erythema marginatum. I will show you one picture of erythema marginatum. So what we are seeing that there is macular erythematous rash. What is there? There is macular. They are not raised. They are macular erythematous rash, and the center is clear. We can see that the center is clear and the margin is erythematous. Okay, so this is macular erythematous rash, which is fade at center, and red at margin. We have to know this. And this is most commonly present on the trunk, present on trunk and extremities. And the face is usually not involved. And what is typical about this rash is that when the patient get hot shower, then these rashes becomes more prominent, and it is also not itching. It do not itch, and they becomes more prominent after hot shower. Becomes more prominent on hot shower. So these are the things we have to know about erythema marginatum. Now the fifth one is the subcutaneous nodule. Subcutaneous nodules. So these subcutaneous nodules are basically present over the joints, skull, in skull, occiput, knee, ankle. They are presented, and they are from few mm to 2 centimeter, and they are non-tender, and freely movable, under the skin. So these are the five major criteria which you have learned in detail. Now we will talk about the treatment part. But before going to the treatment, let's just briefly discuss about the investigation. What are the investigation we have to do is that from this Jones criteria, we can assume what are the investigation we have to send. So for joint like for joint, what we have to send is that we have to send for X-ray joint. Okay, X-ray joint of which joints are involved, like hip, shoulder, knee joint, or the joints which are having symptoms. Such joint access should be sent for investigation. And for heart, what we have to do is that it is carditis. So one is that is PR interval. So for this we have to check for the ECG, and for this carditis and the involvement of the valves, we have to send for echocardiography. So these are the investigations for heart. And another is that we have to send this ESR, CRP, okay, and we have to send for a complete blood count to see for leukocytosis. So these are the basic investigations which we have to send, and along with we have to send this positive throat culture, anti-streptolysin title. These are the investigations we have to send. Okay, now we will talk about the treatment. The treatment which I will teach you, it is taken from Davidson. So now takes about the treatment of the acute rheumatic fever. So at first we should consider about the general measures. So patient with acute rheumatic fever, they should be put on rest, because rest causes it lessens the pain, it lessens the pains and reduce the cardiac workload, okay. And now the second point is the definitive treatment. So in definitive treatment, at first we choose the anti-infective therapy. For anti-infective therapy, the antibiotic which is active against this gas infection is the penicillin. So we give benzathine penicillin G, benzathine penicillin G, 0.6 to 1.2 million unit. It is given on the basis of their weight, their age, either 0.6 unit or 1.2 million unit is given. And if this benzathine penicillin G is not available, then we can give orally, that is penicillin B. And if this penicillin group of antibiotic is contraindicated, then we give erythromycin. And the dose is that for penicillin B, the dose is 250 mg orally 4 times per day. And it is given, it is the single dose, and it is single dose intramuscular, and it is 4 times per day for 10 days. The dose is same for this erythromycin, that is 250 mg orally 4 times per day for 10 days. Now the one is the anti-infective therapy. Now we have to know about the anti-inflammatory therapy, because there is ongoing inflammation, so we have to control in inflammation also. So we also give anti-inflammatory agents. So for anti-inflammatory agents, we have two drugs. One is the aspirin, and another is the corticosteroids. One is aspirin and another is the corticosteroids. So for aspirin, we give a dose of 60 mg per kg per day in 6 divided doses. For 10 weeks. And in adults, the dose is 100 mg per kg per day in 6 divided doses for 10 weeks. And the second drug is the corticosteroid. So corticosteroid, the dose is 1 to 2 mg per kg per day in divided doses, and the duration is that it should be continue until ESR is normalized, and then gradually decrease the dose, So these are the two drugs which we choose. Now if we have to choose between aspirin and corticosteroid, there is one point is that if there is no carditis, we choose aspirin. But if there is carditis, but without congestive cardiac failure, then we can choose either aspirin or corticosteroid. But this corticosteroid is preferred. If there is carditis and with congestive cardiac failure, then corticosteroid is chosen. Okay. And if this aspirin is contraindicated, then we go for naproxen. Now we'll talk about the third point, that is the treatment of congestive cardiac failure. Okay, so for treatment of congestive cardiac failure, there should be proper bed rest. We can give steroid, we can give ACE inhibitor and digoxin. Okay, so this is the treatment of congestive cardiac failure. Now one thing is that if chorea appears, if the patient is developing symptoms of chorea, then we have to give either haloperidol or diazepam. And if this condition gets severe, then we have to go for IV IG. Okay, so this is the point for the treatment. Now if the condition is that like there occurs the residual valve damage, what we have to do is that the medical treatment may fail here, and we have to go for the valve replacement. Now the final discussion is on the prevention of rheumatic fever. So for prevention of rheumatic fever, there are two types of prophylaxis. One is the primary prophylaxis, and second one is the secondary prophylaxis. So if there is pharyngitis, it may proceed to acute rheumatic fever, and again it may proceed to rheumatic heart disease. So the intervention which we do here to prevent pharyngitis progression to the acute rheumatic fever, we have to do the primary prophylaxis. Okay, and for this acute rheumatic fever to rheumatic heart disease, we do secondary prophylaxis. So for this primary prophylaxis, what we do is that we give the single dose of benzathine penicillin G 0.6 or 1.2 million unit, or we give 10-day therapy of penicillin V 250 mg QID or 500 mg BD. If allergic, then erythromycin, the dose is same. But this primary prophylaxis is given if patient comes within 9 days of development of sore throat. Development of sore throat. So if patient comes within 9 days of development of sore throat, for primary prophylaxis, we give this benzathine penicillin 1.2 million unit as a primary prophylaxis to prevent acute rheumatic fever. But this if for the secondary prophylaxis, but for secondary prophylaxis, there is a duration which is given by the American Heart Association, which is taken from the edition. It has mentioned that if there is patient without proven carditis, if there is patient without proven carditis, then duration of prophylaxis should be for 5 years. For how many years? For 5 years, or till 21 years of age, or whichever is longer. Okay, and if the patient is with carditis, then the duration of prophylaxis is for 10 years. For how many years? For 10 years. And for 10 years, or till 21 years, or till 21 years, or whichever is longer. And if the patient is having more severe valvular damage, the treatment is given up to 40 years. But in some case lifelong, sometimes lifelong. And the fourth condition is if the patient has undergone the valvular surgery, then the treatment should be given for lifelong. This prophylaxis should be given for lifelong. So this is the table which is given by the American Heart Association for the prevention of this rheumatic heart disease. And now we know how frequently we have to give this antibiotic. So this penicillin G, so this for secondary prophylaxis, this penicillin G is given 1.2 million unit, or if the patient is less than 30 kg, then we give 0.6 million unit penicillin G, and it is given either every 4 weeks, or every 3 weeks, or every 2 weeks, according to the condition of patient. And if the patient is allergic, and then the patient is not having the penicillin G, then penicillin B can be given. Then penicillin B, which is in the oral form, it can be given, and its dose is 250 mg twice daily. And if the patient is allergic to this penicillin, then we give erythromycin. The dose is same, that is 250 mg BD. So along with this, I completed my topic for this rheumatic fever. Hope you like this video. Please share this video to your friends if you find something helpful from this video. Thank you so much, and do not forget to like, subscribe, and hit the bell icon to get the notifications earlier. Thank you so much.